Hello, and welcome to the latest installment of Where We're Going. I'm Dolly Duffy, the Executive Director of your Notre Dame Alumni Association, and I'm so happy to be with you today. Before we start today's discussion about healthcare, I wanted to share a little bit about the ThinkND community that each of you are now a part of. As you may know, we launched ThinkND in September of 2019, and how fortuitous it was that we launched it and had enough time to get up and running before this pandemic. And now we have more than 16,000 people in more than 100 countries who receive the weekly digest, learning from each other and from Notre Dame faculty. More than 50% of these people take part in a series like this one, the custom learning communities that you can find only on ThinkND. And these communities are a testament to the dedication and talent of your campus partners who work so hard with us to bring ND to you and for your desire to continue learning and growing. Now, before I turn it over to Bernard, I also want to let you know about a new feature that you'll find in some of this semester's ThinkND events called Community Circles. These will typically be held immediately after our discussion and will be an opportunity for you to continue the conversation, if you're so inclined, for about 15 minutes. Think of it as a post-event reception. And I don't know about you, but I am really missing the receptions that we usually have all across campus. Instead, here we'll have breakout rooms and use this time to chat in a casual setting and to share some final thoughts about this event. We hope you'll enjoy this new feature. And in the meantime, if you have questions for our speakers, and I'm sure you will, please use the Google form that we are sharing with you now. And please submit your questions here. And now, I'd like to welcome our moderator for today's event, from the class of 1975, Dr. Bernard Nahlen, the director of our ECK Global Health Institute. You can read his bio in ThinkND, and I strongly encourage that you do because it's quite impressive. But I want to highlight that Bernard is one of our alumni who has come back to serve Our Lady's University and lead the work in global health. He has spent his career working to address the many diseases that disproportionately impact people in low and middle income countries. Immediately prior to coming back to Notre Dame, he served as the deputy coordinator of the US President's Malaria Initiative. Bernard, before I turn the conversation over to you, I'd like to ask a question, and I hope it's not too big. Are there any lessons that you could take from your work on malaria that could be applied to our current coronavirus pandemic?
Yeah, thanks, Dolly. Certainly, I mean, I think there's a lot of features related to malaria and frankly, the success of the fight against malaria over the past 20 years that apply to COVID-19. One of those is the importance of international cooperation. As we say in malaria, parasites don't need passports. And in this particular case, viruses don't need visas. And I think we're seeing in real time the importance of having sort of cross-border collaboration and also multinational cooperation. The other issues get into the importance of investment in research and training. I think it's pretty remarkable that, you know, a little over a year after we first heard about this virus, we actually have vaccines that are greater than 90% efficacious. That's astounding, but it didn't happen overnight. It's because of decades of investment in science and training of scientists and public health people. Lastly, not last but not least, the investment in infrastructure for public health delivery, public health services. All of those things have benefited malaria. If you look at the data from malaria, deaths from malaria have decreased by 50% over the past decade. And I have little doubt that we will fairly soon start seeing some of the benefits of the investments as we start looking to see COVID-19 in our rearview mirror. We're really fortunate today to have a panel, distinguished panel of faculty here at Notre Dame. Bill Evans, who's the director of the Lab of Economic Opportunity, Krista Foster, who's an assistant professor in the Mendoza College of Business, and Dominic Vachon, who's director of the Hillebrand Center for Compassionate Care in Medicine. So welcome, Bill, Krista, and Dominic. We're delighted you could all join us today. each of you come from different parts of the university. Krista, you're in Mendoza College of Business. Bill, you're in Arts and Letters, and Dominic, you're in the College of Science. So to get us started, just like for each of you to share a little bit about your background and the work that you lead here at the university. So let's begin with Dominic.
Thank you, Bernard. Glad to be with you and getting to talk about this important area. I'm a medical psychologist. I've spent most of my career training new physicians, also nurses and other helping professionals. Most of my career has been in as a faculty of a residency training program. And in 2011, Notre Dame in the College of Science started the Hillebrand Center for Compassionate Care in Medicine with the donation and vision of Ruth Hillebrand and her brother Joseph. And our mission is to restore a spirit of compassion to healthcare by advancing the application of the science of compassion at every level of training and practice. And that's in order to transform patient care, but also clinician well-being. And so we do this in two cutting-edge ways. One is by science of compassion, I mean neuroscience of compassion, biology of compassion. And we bring this to anybody who wants to work on this, whether it's a training program, a continuing medical education organization. And then the second way we do that, which is very unique, is that we look at the undergrad years as part of the medical training. We don't look at it as the prelude to it. We look at it as part of it. So where we can help lay a foundation in communication skills, but also training their mind and their heart, getting ready for this work.
Thanks, Dominic. I should have mentioned that this is the first of 3 series that we're going to be having this month on healthcare, particularly during this period of COVID-19 and also looking forward after this. So I'd now like to invite Krista to tell us a little bit about her career and research and how that relates to what we're discussing today.
Thank you. Absolutely. So my research is in the area of operations management and supply chain management. So we're more focused on looking at the operational aspects of healthcare and trying to make the delivery of healthcare more effective and more efficient. So that can be more cost effective, but also focusing on the patient quality, quality of care. So I've worked primarily with emergency physicians, and it's a little bit different from other specialties. There's some different challenges there because there's not appointments, and legally they are required to treat any patient that shows up, regardless of medical condition, ability to pay. So there are some different challenges there operationally. And we view the physicians essentially as a critical resource to the healthcare delivery process. And we study how they practice, the factors that affect their productivity, their performance, how the patients, basically how satisfied the patients are, what the quality of care is. We've also looked at the incidence of medical malpractice amongst emergency physicians and how that impacts their practice patterns, as well as the use of other providers such as physician assistants and nurse practitioners in the emergency department. So that's essentially where we're looking at, those operational changes that can make the delivery of healthcare more effective.
Thank you, Krista. So Bill, over to you.
Hi, welcome everybody. Thanks to the Alumni Association for inviting me. My name is Bill Evans. I'm a faculty member here in the Department of Economics. And 8 years ago with my colleague Jim Sullivan, we started the Wilson Sheehan Lab for Economic Opportunities. We are interested in evidence-based solutions to poverty. And we get that evidence by partnering with local social service providers to run experiments of the programs that are designed to either move people out of poverty or try to decrease the consequences of their financial situation. A lot of our work is centered on trying to relieve the health burden that poverty imposes on a number of different families. So some of the projects that we have completed have been things like in Chicago, they had a program to try to reduce hospital readmissions for low-income elderly in the Medicare program by having social workers visit a patient soon after the discharge and make sure they had adequate food in the refrigerator, a ride to their follow-up appointments. They picked up their medicine, they understood their discharge instructions. And we found that program was incredibly effective at actually reducing readmission rates by about 20% among this group. We had another program that we're engaged in Johnson County, Kansas, that tries to reduce the interactions that the mentally ill have with the criminal justice system. With the deinstitutionalization of the mentally ill, there's really been a trans institutionalization, and that the mentally ill are now primarily treated for the criminal justice system, the severely mentally ill, and many of them are. So this program was designed to help move the mentally ill into their lines of treatment soon after they've been discharged from a jail or a prison. So a lot of the programs that we're working with, a lot of the organizations we're working with are social service organizations, Catholic Charities, Lutheran Services, Goodwill Industries, but we're also working with a lot of state and local governments who are on the ground programs trying to fight poverty.
Thanks, Bill. You're highlighting some of the important issues related to how COVID-19 has shown a spotlight on for the health disparities and the difficulties many patient populations have had in accessing health care. But if nothing else, that's been further become even a bigger problem under COVID-19. Bill, you've been looking at mortality trends during COVID-19. Just wonder if you could share a little bit about what your findings have shown and where are the pockets where the populations have been particularly vulnerable, and also what can be done about this?
So, our work at Leo is focused on the poor, and COVID has been a particularly bad disease for those who are vulnerable. So there's been about 470,000 people that have died from COVID already. And if you take a look at the people that are particularly most susceptible, they are vulnerable groups. And so the aged, people in nursing homes, people with dementia, especially Alzheimer's, are incredibly high mortality rates from COVID. Then if you take a look at particular demographic groups based on race and ethnicity, so minorities, especially minority men, have incredibly high mortality rates. So just on the aged front, 81% of all the deaths from COVID have been people 65 and older, and a third of the people are 85 and over. So this is a very deadly disease for people with more advanced age, compromised immune systems. As the disease that strikes the elderly, if you compare the death rates for Black and Hispanic 65 and over, these minority elderly groups are dying at more than twice the rate of non-Hispanic whites. So it's been particularly devastating in the minority community as well. And what we don't know now is whether this is due to just higher infection rates or higher mortality conditional on infection or poorer treatment alternatives. We're still sort of at the beginning of that. For me, maybe the most unsettling number to date has been that 40% of the deaths from COVID have been for people in nursing homes. About 10% of the nursing home population that existed at the beginning of 2020 has died from COVID since February. And these deaths continue today. In December of 2020, a third of the deaths that occurred in that month were for people in nursing homes. And so this has been a particularly devastating disease for people who already were relatively vulnerable on the medical care side.
Yeah, thanks, Bill. I mean, I think the other thing we're seeing in the midst of this COVID pandemic is not only the direct effects of COVID on morbidity and mortality, so the severe disease and deaths, but also the indirect effects. How, some people who before were able to access treatment services, that's been disrupted, not only for treatment services, but even for prevention. I go back to childhood immunization programs, which have been disrupted also by the COVID epidemic. But when it comes to mortality, we keep hearing this term excess mortality. So I just wondered if you could say a little bit about what do we mean by excess mortality, and what is it that we're measuring in this pandemic?
So excess mortality is the number of deaths above what we would expect given historical data. So for example, we've experienced about 2.8 million deaths per year from, say, 2015 through 2019. In 2020, we have about 500,000 more deaths than we would have had compared to those numbers. And so mortality is substantially higher in 2020 than it was before. So there are two things important about this. The first is that the vast majority of these deaths are from COVID. So 2/3 of that 500, or about 350,000 just in 2020 alone, have been from COVID. But the fact of the matter is that there's about 150,000 more deaths that are occurring in that year that aren't due to COVID at all. So there's a death toll associated with COVID, but also there's tremendous mortality from these non-COVID causes. Now, where are these deaths coming from? The first thing they're coming from is from social isolation. So the voluntary shutdown that people are doing in their own lives, the shutdown that's occurring, the social isolation in nursing homes, those that are generated by the governments, have really put a strain on individuals. This is particularly problematic for the young and for Alzheimer's patients. So where is it showing up in the young? It's showing up in higher drug use rates. It's showing up in higher suicides. And far and away, the group that has the largest excess mortality from non-COVID causes are Alzheimer's patients. The lockdown itself is generating tremendous amount of unemployment. If you take a look at the employment of high-wage workers, it's about the same as it was in pre-pandemic times. But if you take a look at low-wage workers, they're substantially out of work compared to their employment levels in February. So that group has been particularly affected. And then the last thing that we have to worry about is it's been this massive decline in medical care use for non-COVID reasons early on in the pandemic. So from March to May, as individuals shut down, private businesses weren't meeting with clients, meeting with patients, there was a huge decline in diagnostic testing, routine medical exams, people picking up their prescriptions. And so there's obviously been delay in getting medical care, and how that's going to play out over long term, we still have to figure out.
Thanks, Bill. I'm going to turn to Krista now. Some of the trends we're seeing now in the midst of COVID were sort of starting before. I just think of telemedicine. I think most of us have had some experience with having medical appointments virtually at this point in time. But Krista, I'm just wondering, what trends will we continue to see in the delivery of healthcare as organizations seek to reduce costs? And how will this amplify the need for better care coordination capabilities and data interoperability?
Yeah, there have been several trends that have been accelerated by the COVID-19 pandemic, including telemedicine. So that's actually being used more and more in emergency departments. Like I said, that's my area of research, and there have been several different ways in which it has been used. Some patients are actually physically in the hospital in the ED, and they're still having these virtual appointments. Some are remote. Sometimes it's just used for triage. So it's not clear which is the best approach. So studies are still trying to evaluate which is the best approach to make the patient experience the most effective in that way. There's also a push. I mean, we all know that, if you have to go to the hospital, whether it's the emergency department or an inpatient visit, there's a very high cost. And if you were able to have that taken care of at your primary care provider, it would usually be a lot less costly, but they have limited hours. You have to make an appointment. You might have to wait for an appointment. So sometimes the patients that go to, for instance, an emergency department are going there out of convenience. They're trying not to miss work, or they don't have the time, they can't wait as long for an appointment. So it's not necessarily a true emergency. And I think there's, facilities like urgent cares are popping up more and more that have these extended hours that can pull some patients that are not experiencing as severe life-threatening conditions away from the EDs, away from the hospital, and into these urgent care facilities. Emergency departments also have been more and more implementing what's called a fast track, where the less severe patients are pulled through basically into a different line and treated more quickly. And in both of those cases, you're seeing more and more patients treated by nurse practitioners and physician assistants. That's a trend across many specialties that I think we'll continue to see, because it's a way to reduce costs while still maintaining the quality of care, but also to alleviate strain that there is due to a shortage of physicians. And so in that way, I think that there's the data provide, electronic health records provide a very complete picture of a patient's care. And the more that a physician can have that up front, the more helpful it is. And when you're pulling patients away from hospitals to these other facilities, even within the same healthcare system, I think it's really crucial to coordinate care across the various locations. And it's going to be really important to maintain these complete records and be able to use that data effectively.
Thanks. Obviously, another important issue related to healthcare costs has to do with medical malpractice claims. So can you share with us how medical malpractice claims affect the cost and delivery of healthcare, and what are the implications of this for doctors practicing defensive medicine, as it's called? And is the threat of medical malpractice litigation a major obstacle to reducing healthcare costs, or is it critical to ensuring provider accountability?
Yeah, so first thing I want to say is, just because a physician is named in a malpractice lawsuit does not necessarily mean that there's any wrongdoing that actually happened. But the actual act of being named in this lawsuit can cause a lot of stress for the physician. And interestingly, like as many as 90% of physicians have, admitted that they have practiced defensively. So that might be ordering extra tests, observing patients for a longer period of time, or it could even mean, doing additional procedures. So in some ways that aligns very well with how physicians are trained. You want to diagnose certain conditions and rule out other conditions. But in some cases, it can be excessive and it could lead to additional costs. So we did a study where we looked at how being named in a malpractice claim affected emergency physicians' behavior. And it actually provides a really good setting, because emergency physicians they're not constrained by things like, referrals from other physicians, and, they're working at a much faster pace. They don't have to wait for insurance approval. And so we wanted to see, okay, if you're named in a malpractice lawsuit, does that cause you to then become more defensive and start, over ordering tests and doing additional procedures, admitting more patients? And we were very happy to find that, we saw it as a positive that didn't happen. Not a whole lot changed in terms of what was being ordered, which is good, because it's saying, there doesn't need to be an intervention there. They're not inflating costs further once they're named in a lawsuit. So yeah, I think that there are high costs that are associated with both this idea of defensive medicine and malpractice claims. I don't think it's realistic to think that, malpractice claims are going to go away. That kind of litigation is going to be present. But the one thing that we found that we thought was really interesting was this idea that patient satisfaction scores from surveys that patients received were actually higher after the physician was named in a lawsuit, which suggests some sort of change, maybe something that's intangible, the way they communicated with their patients, or maybe they showed a little bit more compassion, something like that. So that was one of the interesting results. But yeah, I think the costs are going to be hard to avoid. They are going to be an obstacle to reducing costs, but I think that we just have to accept that they're there.
Thanks, Krista. Dominic, obviously there's been a huge impact on healthcare workers during this pandemic, both their physical health, but also their mental health, for
Yes.
the work of themselves with their families. So patients love the idea of compassion in healthcare, but I guess the question is it really essential?
Mhm.
And doesn't that just contribute to burnout of clinicians? And along the same lines, can compassion actually be taught? And if so, how are we training our healthcare professionals?
Yes, everybody loves the idea of compassion in healthcare. So when people want to sell it, they'll usually have the words caring and compassion right there in the advertisement. And it turns out when you research this, actually physicians and patients and nurses are all in agreement. All of them believe compassion is essential. But then what happens when you get in there and then the actual practice, people go, is this really necessary? Well, the research has turned out pretty clear that when you practice in a compassion-centered way, everything gets better. Patient satisfaction improves, actual medical outcomes get better because the providers are into it. They're really focused in what's going on. And then the other thing it turns out is that the clinicians themselves benefit from compassion. The amazing thing we've learned from science of compassion, especially recently, is that not caring for people is actually more hazardous for you than caring. And so it's not compassion that's burning people out. It's actually compassion that's helping people keep going. And like right now, we're doing a research study with physicians in high stress clinical specialties. And over again, what I hear is, this is what I was built for. This is what I've got to do. But running a marathon every single day is just a lot. So this is not a problem of compassion. This is a problem of what we've got to deal with. But compassion is what keeps people going. So the not caring is actually more hazardous to you. That's a paradoxical thing. A lot of people think, well, you either have compassion or you don't. We actually have been finding that that's really not the case. If you're a human being, human beings biologically are built for compassion. So when we're not compassionate, we're actually violating our own human nature. Well, in healthcare training and practice, we build on that. Biologically, you're built for compassion. But when you're in healthcare, it's healthcare, it's compassion on steroids. So how do you help people work at this intense level? And so we find that you can teach that. But doing that requires that, well, we've got to do two things. First is, how do you communicate? How do you deliver that to people? How do they perceive what you're doing? The other important thing in teaching this is to help clinicians, help people in training, help them train their minds for this. So in other words, to learn the skills you've got to have and to be able to do them in an emotionally composed way, but then being able to really engage people who are suffering and to keep doing that and to help people learn how to do that in such a way that they're not overwhelmed by that suffering, but they can hang in and keep going. And that's the fascinating thing, is that compassion is really the key variable. One of the cool things we've learned is that compassion is actually different than empathy. If you have empathy by itself, it's like an open channel where you're not regulating what's going on. Compassion is kind of the chassis, the undergirding, holding that empathy, and helps you keep balance, helps you keep mentally focused and motivated. So it's very cool what we're learning, but we've got a lot of work to do to help people learn how to do this. And the other thing is, it's really important not to blame the victim. So when people burn out, it's really easy to go, gosh, what was wrong with this one? Let's get another one. One of the big things we know is that systemically, organizationally, that's where the big changes need to occur to really support the compassionate people who are there. So it's really important that we don't go, oh, it's compassion's fault, or it's that doctor's fault. It's like, it's a big picture too. What kind of systems do we have that can help people or undercut people in doing this good work?
Those are some very interesting points, Dominic. And I just wanted to follow up. I mean, Krista had referred to the sort of ramping up of telemedicine, which is happening during COVID-19 and is likely to continue after COVID-19.
Yes.
Just wondered if you could comment a little bit on how the movement towards telemedicine potentially impacts the role of compassion.
Yes.
How that plays in care.
You know, our thinking on this has really evolved. And like, we do a medical counseling skills class where we use simulated patient actors. And with COVID, we've moved our training to be both in-person, protected, as well as helping our students using, seeing patients. We train them on telehealth. And at first we were like going, oh my gosh, we can't shake hands. We can't do everything we'd normally do in person. And then we're like going, wait a second, telemedicine is a way that we can be compassionate in a safe way. So we're doing this now because we have to, but this is going to be a way that we reach out to people who are, for example, don't have access to certain specialties. And so what we're doing now in telehealth training, in terms of, quote, the bedside manner through FaceTime or Zoom or whatever, is learning how to communicate that you're really caring about this person, using, making sure you're looking at the camera in a way that's helpful, getting to know the person, connecting with the person. And like anything else, are you into it? Are you really listening to this person? Are you like showing them that you are applying your brain to their problem? And so people feel like very happy that you are really trying. So we're actually learning that while it's not the first choice, telemedicine, there's really great ways to show people that you really do care. So it's really, it's evolving for us. Again, you can't examine a person well in telemedicine, but on the other hand, you can really help people, guide them in terms of what's the next step. Do they need to come in? Do they need to go to the ED? And that is a huge compassionate thing.
Thanks. We have about 10 minutes before we open the floor to questions from those online who are with us today. So let's open it up a bit. Each of you looks at today's world from a very different vantage point, and each of you have considerable changes over the years. So I guess the question is, where do you see us headed? I mean, based on what you've seen, what is it that gives you hope and what gives you concern about the coming decade that we should all be paying attention to? Let's go back to Bill and start with Bill.
Well, what I'm hopeful is that we can learn something from this devastating effects of this past year that are going to help us moving forward. So for example, let me give you one. The U.S. medical care system is equally described as this technological marvel, but also this uniquely wasteful endeavor. We spend more per capita on medical care than any other country, and we have really poor outcomes. But if you ask, where do you want to, if you were to pick where you want to get treated, you want to get treated in this country. So we're of these two very distinct images of the US healthcare system. Well, I think we're going to learn a lot about where the value is because of what has happened as a result of COVID. There's a lot of people that have missed appointments, missed treatments, missed diagnoses. And over time, we're going to learn which ones are really important and which ones were not. So hopefully, we're going to have at least some reevaluation of what's really important on a day-to-day business in the medical care system, and what maybe is not as important. So I'm hopeful of that. The one that I think is going to be a little bit more difficult for us to figure out is how we failed seniors in nursing homes so miserably during this pandemic. And so a pandemic comes, it hits nursing homes. And so the first thing we did, which was a natural response, is just to isolate people in the nursing homes to stop the spread. No community meals, no joint activity. My mother's an Alzheimer's patient. In a nursing home, she's eaten off a TV tray in her room since March by herself. That's not good for people. And so it's a natural response. Now, we would be applauding this if it were some degree working, but the fact of the matter is, in December, there were 5,500 people who died a week in nursing homes. It was still a third of all COVID mortality. And there's tremendous amount of difficulty of patients in nursing homes because of this isolation. So we're kind of getting the worst of all the possible worlds. We're not stopping COVID there, and people are dying of loneliness. And so we're going to have to rethink what we're doing in nursing homes, because this has kind of exposed some really big problems there are in that sector. So are we going to find solutions? I don't know, but I think it's going to help us at least focus on some problems of sort of the dignity that we have to make sure that people in those situations have, even in these very difficult times.
Thanks, Phil, for those some great points. So I'll turn to Krista. Krista, what keeps you up at night, and what do you think we should all be concerned about going forward over the post-COVID?
So yeah, concerns. I feel like Dominic and I have both mentioned telemedicine, and I think one of the big concerns is access to that, right? So there's certain populations that are not going to have the same type of access to telehealth. And I think there is a bit of a concern there, and how can we, get around that? So can't completely go to, you always have to have the option that patients can physically go in and see someone in a safe way. Excuse me. And like I said, I think that it's interesting in terms of the emergency department setting, just to see what's the best way to go about that. Because if you are experiencing a true emergency, it's not going to help you, right? To see someone virtually, that, they might be able to tell you need to go to the emergency department right now. But if you're experiencing a true emergency, that might be actually delaying, your treatment, and it might be a negative effect. In terms of the things that give me hope, I think just over the past several years, there's just more and more use of data to make decisions. So I think that's, from my perspective, my background, that's something that I see as really promising. So both, like I said, operational decisions are being made using data, but also, personalized care being made, based on your test results, what treatment route is best for you. And I think that's a really exciting trend. There are some challenges, especially I think with payers, to make sure that you have the approvals and everything like that. But I think it's a really interesting way that things are going. And from my field, one of the things that we always notice is that healthcare always lags a little bit behind in terms of adopting some of our new technologies, and there's reasons for that. You have the sensitivity of the data, patients' lives are at stake, all of those things are important. But I think that there's, with more security measures and more data being collected, that I'm really hopeful about how that's going to be used to make better decisions.
Thanks. Those are some great points as well. Dominic, we have a few more minutes, so really like to hear from you on what you think, what are the hopes and concerns going forward?
Well, the first thing that hits me is the next six months to a year, 2 years. I think the thing that worries me is that we're all exhausted and demoralized. So we're talking patients, we're talking loved ones, we're talking healthcare people, we're talking helping professionals in general. So I work a lot with working with healthcare people in healthcare. And what I see is that people in healthcare are exhausted. And many of them feel betrayed and discounted. So like, wow, you guys didn't notice that we were working marathons every day, or you didn't care, or, so there's a lot of healing that's going to need to take place for everybody. A lot of healthcare people, and I'm thinking everywhere from CNAs to physicians, healthcare management, but I'm also thinking people like school teachers and others who do this helping work. They feel like commodities. They feel like they're taken for granted. And so people take compassion for granted, and it's sort of like a light bulb. Well, this one burnt out. Let's go get another one. They're easy to replace, right? Let's get an LED this time so it lasts a little longer. And people who work in healthcare as well as other helping professions are like, no. You're treating us like a commodity here. This is a tough thing to do. So I think what's going to go on here, and this is similar to what Krista and Bill are saying, and Bill started with this, I think the hope here is that we are getting really clear about what really matters. Like, I think we've got a period of financial and psychological healing and renewal that we're going to have to do. But yesterday I was interviewing an ICU doc who just went through a huge surge and saw many people die. He said, you know what, this has really clarified, it's crystallized what really matters to me. And he says, I have a sense of peace about that. He says, this has been grueling, it is hard. But on the other hand, I am really clear about what I am about. And those words really are staying with me, that the priorities are getting really clear. And so that's what gives me hope, is that I think we have an opportunity. This is not an automatic, but we have an opportunity to go, wow, it really matters how we take care of each other. Let's work on that. And that's about compassion.
Great. Thanks, Dominic. We're now going to open this up to our colleagues who are with us and listening in. So we invite each of you to fill out the form that you see in the chat function, or to submit in order to submit a question to the panelist. And while you're doing that, in the meantime, I'm going to start with a couple of questions that were submitted in advance. There's a question here on health equity remains a serious concern. A current issue is equitable access to COVID vaccination for Black and Latinx communities, despite the disproportionate impact of the pandemic in these communities. Please share how this can be addressed with any examples of current successful efforts. Bill, maybe I'll direct that to you, since you sort of touched on some of this earlier on.
So the vaccination rate is going to have some success early, and then the success is going to taper off, because you can vaccinate people easily in congregate settings. You can bring the vaccine to them. But what you really need is a fairly detailed, a central location in order for people to come to, in order for this to work. Florida seems to have some reasonable success with this, and that early on they've had some pretty high vaccination rates. Now, part of it is also they've had a lot of, they're a very old state, and the priority was for the elderly first, and so just a larger fraction of people were eligible for the vaccine early on. But I mean, the problem is one of logistics. It's hard to go to people because everyone's dispersed. And so you got to build a system where people can come to you. Now, what's the problem? The problem is, well, we think public transportation is actually a real risk. If you take a look at where the COVID hit the most in New York City, it's right along the subway lines. And so, no, I mean, no, you can wear masks and you can have less capacity and things like that. But it's a real challenge. And it's also the case, though, that in some settings, especially for people with with lower income, they just don't have the transportation in order to get to, say, an airport or a baseball stadium in order to get the vaccine. And so it's going to be a real challenge in order to get the vaccine to some difficult to serve populations, because the problems that make their healthcare difficult right now, lack of transportation, things like that, are going to make it difficult to deliver the vaccine as well. Hopefully by the end of November, by the end of February, beginning of March, we'll have everybody in nursing homes covered, and that's going to take like enormous numbers of people out of the equation. So that should really decline rapidly starting in March once the nursing homes, because that's 40% of mortality. And then we got to start working on just moving down that age spectrum. Young people, they're just not at risk. People 50 and older are much higher risk, and so we got to work on that group. But they're living in the same place the young people are in most situations. So the staging is a difficult supply chain problem in this context.
Thanks, Bill. Dominic, there's a question here directed to you. What traits do you consider to be included in the concept of quote unquote bedside manner for physicians? And does that include compassion and empathy?
Absolutely. And again, I hope you didn't hear me as saying that empathy is not good. It's that empathy has to be carried, and compassion is the vehicle for that. Well, I can sum that up, and we have a trick question in one of my classes. And at the end we go, would you rather have a smart doctor or a caring doctor? And of course, if you pick either one, you fail because we don't separate competence from compassion. So the key is, well, in terms of traits, the biggest trait is that you are totally present. You are ready to apply your competence, your skills to the person in front of you, and that you do that in a connecting way. So having your competence and your willingness and emotional composure to apply it, but then how you deliver that, both of those go together. So the answer to that question, would you rather have a smart doctor or a caring doctor, or a smart nurse or a caring nurse? The answer is both of them, because a smart doctor is going to know that you have got to apply yourself completely, stay up on the research, but that doctor is also going to know that it matters how you deliver the medicine. And so that knowledge and there's a wide range of bedside manners. And what we know from the research is patients can tell when you are into it. They can tell when you are authentically trying your best. And they can pick that right up. And so there's actually kind of a wide range of bedside manners. The key is, are you invested? Do you really care about that person in front of you?
Thanks, Dominic. There's another question here, which is directed to everyone, and that is, what can we do now to help? So, Krista, maybe I'll just throw that to you at the moment to see if you have any ideas from your perspective on what those listening in might be able to do.
So, I think that from my perspective, we look at a lot of different interventions that can be, we, testing, like I said, with data, I'm, a big proponent of using data. So, taking that, doing this intervention and then seeing how does that play out? Was this effective or not? And I think that's these smaller experiments in smaller settings, and then you can expand them when something is working well. If that makes sense.
Maybe I'll just ask Dominic and Bill also, if you have any thoughts on what folks listening in might be able to do now to contribute.
I think the social isolation that people are experiencing is very troubling. And it really is heavy on young people and the elderly. And so making the effort to check in on the neighbor, to check in on the relative, to check in on the grandparents, to understand what's going on, I think is really important. The other thing is, we got to get these schools open. I think we've learned a lot about the virus, and we've certainly learned how to protect faculty. And certainly in the K-8 system, transmission from children to adults is relatively difficult. And so I think people need to campaign heavily within their local school district to reopen these schools, because what's happening to children is they're going to lose 2 years of education, especially in very poor districts where they didn't have such great quality instruction, and they have crappy Wi-Fi now, maybe not one computer, they're sharing among 2 or 3 siblings in order to get classes. And so the more people can agitate to get these schools open, I think is important, because what's happening to children, I think, is just really quite shameful, and especially to really low-income kids. So the more that we can do to get these schools back open, the better off we're going to be, because I think when all is said and done, they're going to be about 2 years behind, especially in really poor districts.
Thanks, Bill. Dominique, from your perspective, what would you think folks could do now?
Of all the questions that I was prepared for, I wasn't really prepared for that one. So I have 2 reactions to that question. My first one is, well, we're trying to get these programs off the ground. Help us get that going. That's a more local kind of thing. But thinking in terms of everyone, I'm thinking, it's similar to what Krista and Bill are both saying. It's like wherever you are, really thinking about, okay, we all want the same things here. We're all trying to get through, trying to be happy, trying to help out. Looking for any opportunity we have to notice what people are going through and to care about that and to actually do something about that. And, one of the things that I really seen over the year in terms of media is that everything counts, the small things, the big things, thinking about people like, okay, who is being forgotten here? Or if it's a person who is a school teacher or works in a nursing home or is caregiving and can't see their loved one in a nursing home, where we're reaching out to them and saying, hey, what are you going through? I want you to know I appreciate what you're doing, or I want to know what you're going through. I think it's wherever we are that we, as hard as this is for each of us, to kind of go and, hey, okay, what can I do to help you out? Or who have I forgotten today? And I think that's, like I said, in terms of the biology and neuroscience of compassion, this is what we're built for. This is why we humans supposedly succeeded as a species. It's because we had compassion in our genes. And so I'd say, speaking globally, it'd be like, let's engage that. Let's just figure out wherever you are, whatever you're doing, notice what is going on and let it move you.
You need to turn on Bernard.
Sorry about that. I was just saying we're running out of time, and I've just taken up more of it by not unmuting myself. But there's a lot of questions have come in. Some of these relate to the importance of communicating with the public about the importance of randomized controlled trials. I know that's something that people involved in research and also the ethics of doing that during a pandemic. So I think some of these we could discuss in the follow-up chat rooms for those who can hang around. And also some suggestions on how Notre Dame might position itself vis-a-vis other things going on campus that folks are aware of. So we're going to move on a bit here. As we said, first of all, thanks to everybody for joining us today. Next week, we'll have the National Viewpoint, where we will hear from US-based practitioners discussing trends in healthcare. So please feel free to share this with your friends. We're accepting registrations throughout the entire program, as each meeting can stand alone. You'll now have the opportunity to join a community breakout room for 15 minutes to continue the discussion with your peers and our faculty leads. Please note that if you choose not to participate in the breakout rooms, you may leave the meeting and join us again next week.